Welcome to Brazos Matters. I'm Jay Sokol. We have a mega guest today, so there is no time to mess around, Matt. All right, we're going to get straight to the good stuff without my usual ramblings up front. Today's guest is Dr. Leonard Berry, a University Distinguished Professor of Marketing and Regents Professor at Mays Business School at Texas A&M University. He is a Senior Fellow at the Institute for Healthcare Improvement, a past president of the American Marketing Association. He has studied healthcare service improvements in association with the Mayo Clinic, Henry Ford Health, and other health systems. Much of Dr. Berry's work has focused on service delivery in cancer care settings. So today he is with us to talk about some newly published research he participated in called Never Words: What Not to Say to Patients with Serious Illness. And I think all of us can relate to this topic. So Dr. Berry, it is an honor to have you here.
Well, thank you, Jay. It's my pleasure.
Okay, let's get right to it. What are never words and why make it the focus of your research?
Never words are words, phrases that doctors use, usually unintentionally, that can offend patients, that can scare patients, or that can stop a conversation in its tracks because there's nothing more to the patient. The patient can respond when a never word or never phrase is said. And so we studied, physician co-authors and I, we studied never words to illustrate this concept. We published our research in a medical journal, one of the leading medical journals, and the research has actually gone viral. It's more so than we ever expected on social media and publicity and the kinds of interviews such as the one we're doing today.
Viral among the general public or within the medical community?
Both, yes. Just a lot of interest. And the reason is never words are harmful. They're harmful emotionally. And in medicine and healthcare, we have to think not only about physical pain, we also think about, we have to think about emotional pain. Mm-hmm. And sometimes, too often, clinicians can create emotional pain with the words that they use. They don't intend to, at least not very often, but they will frequently use what we call never words.
Do medical schools or healthcare systems teach this sort of thing?
Not enough. There's so much science that a medical student has to learn. And the first 2 years of medical school typically are just overfilled with the science training. So much so that a number of my students who've gone on to medical school, because I teach a healthcare class at the university, will tell me later that it's hard to remember why they wanted to be a doctor in the first 2 years of medical school because they're just being bombarded with all of the science, which they need.
Right.
They become scientists, but they also need to be great human beings in interacting with their patients because their patients are afraid. They're afraid. They're scared. They may be in pain. They're uncertain. And they need kindness and humanity and compassion in addition to good science.
Why did you feel like, or when did you feel like, this is something you needed to look into more?
Good question. You mentioned in the introduction that I do much of my research in oncology. And in interviewing oncology nurses, oncology physicians, oncology surgeons, one of the words that I would typically, one of the questions I would typically ask in my interviews is there a certain word or phrase you would never use with a patient? Every single clinician that I asked that question to had a certain never word or never phrase. And so I started taking notes. I have a long list of examples. We put some of them in our publication. And that's what got me interested in this issue, that we needlessly create emotional harm with phrases and words that we use in interacting with patients in their most vulnerable states as consumers. There's a reason we call consumers patients when they're getting medical care, because they're in a different state of mind, and they may be in distress, physical distress, emotional distress, and they need the best of what we can give them, not only medically, not only in terms of the science, but in terms of our humanity.
Right. So I'm going to make a guess. You tell me if I'm right or if I'm very wrong. Is there a generational difference about the kinds of words and phrases that are used? Because my hunch, if I was taking a guess, would be that maybe older physicians would use words and phrases that are not as sensitive to this as maybe they should be. And the younger the physician is, maybe the more diplomatic they are and sensitive with their language. Right or wrong?
I am not sure. I don't have the answer to that question empirically, because we did not study age differences in the use of never words, the frequency of the use of never words. But my guess, Jay, is, sorry, friend, that you're wrong.
That's shocking that I would be wrong about anything, but go ahead.
Yes. My guess, even though I don't have empirical evidence, is that you're wrong, because physicians learn a lot of their behavior, including their communication behavior, from their mentors, from the physicians that teach them in medical school, that teach them when they're in their residency training. And that's where they learn the lingo.
Yeah.
Behaviorally, including their communication. And so this is how physicians learn to talk. This is how they learn medical language, is they learn from their teachers. And I haven't seen anything in the literature that would suggest that we're getting better, more sensitive, more compassionate in our language in more recent times.
Right. So your published findings focused on very specific words and phrases, and I'd love to go down that list so you can explain why each of these might be harmful to patients and families, and maybe if there are better options that exist. Because some of these, I thought, are these real? Like, could these really be words and phrases? So you get to talk me through these. There's nothing else we can do.
There's always something more that clinicians can do to help their patients, even when it is no longer possible to provide curative treatment, to provide treatment that can help the patient suppress the disease, cure the disease. Even then, there's much more that the physician can do. And so when we say as a physician to a patient, there's nothing more we can do, we're basically communicating abandonment. And that can be emotionally devastating. Let's say you're a cancer patient and you've been treated by the same oncology group and the same physician for 3 years in your journey with cancer, and then you hear there's nothing more we can do. That's devastating, because you become so close to your physician. You become so dependent on your physician. You're so vulnerable in that state. with colleagues. I've written other papers about what physicians can do when curative treatment is no longer indicated. They can help patients gravitate to a new form of hope, where patients who are in a life-limited state can live a better quality of life as long as they live. Because as long as you are alive, then quality of life is important.
Yeah. This is the one that really surprised me. Circling the drain.
Yes, circling the drain. My co-author, Dr. Oddish, on the Never Words paper, she is a critical care physician at Henry Ford Health in Detroit, and she became suddenly critically ill and wrote a fabulous book about her illness and her experience as a critical care physician who became almost instantaneously critically ill and then treated in her own hospital. And her book is titled In Shock, 2 words, and I highly recommend it to your listeners, your viewers. In her book, she uses that example where in earshot, as she was close to death, one of the physicians said to the other clinicians in the room, and she overheard it, "She's circling the drain."
Wow.
And that was so offensive to Dr. Oddish, the patient, that she wrote about it in her book. She told that story in her book, and we use that as an example in our paper.
That one's really surprised me. How about everything will be fine?
Well, the problem with everything will be fine is it's often dishonest.
Yeah.
And it breaks trust because, unfortunately, we're all going to get sick to a degree that everything will not be fine, every one of us. And so when a doctor says that, when it's not true, then it's a break in trust. It's a falsehood. Patients need to know the truth. They need to know it in the right way. There's a wrong way and there's a right way, and it's not easy. Mm-hmm. These are the hardest conversations physicians have to have. And I have a lot of empathy for physicians having to have these conversations. It's not easy.
Right.
But what patients need is they need the truth gently, but they need the truth. I refer to it as gentle honesty, so that they can prepare themselves emotionally, so they can prepare their families, so they can decide how they want to spend the days that they have left.
Yeah.
And many patients, if they knew the truth, might decide to spend the days they have left outside of a hospital without all kinds of instruments and equipment and drains and everything else plugged into them. And this is an area of great interest to me, end-of-life care. I've studied it for years. I've written about it with hospice physicians, with palliative care physicians who know much more than me and have taught me a great deal. And I just think it's a great opportunity that we have in American healthcare to improve the quality of end-of-life care. And one of the ways we do that is with being gently honest with our patients so they can make the best decisions about what matters to them.
I'd love to go through a couple more examples. The words fight and battle. Talk about those.
Yes, fight and battle are never words for sure, because they're military words. And military words suggest winning or losing. And what they convey, potentially convey to the patient, if a physician says, Jay, you need to fight this, is when the patient, when the patient becomes more sick, more ill, and the patient dies, then there's the issue. Well, maybe I didn't fight hard enough.
Yeah.
You know, and maybe it's my fault, but it's not the fault of the patient. So the use of military words in medicine is wrong. We should never do it. And that's why we use those examples.
Another example in your published research, this one surprised me too. I don't know why you waited so long to come in. That's harsh.
Yes, it's harsh, but it's all too common, particularly in disease states like cancer, because human beings often put off, for a variety of reasons, including fear of a diagnosis, put off going to get that diagnosis, put off going to the doctor, even when they're ill, not feeling well, wishing something to go away so they don't have to go to the doctor or get tested. The problem is it creates a sense of guilt that's unnecessary. If you've been just diagnosed with cancer and you could have come in, a month or two earlier than you did, you have plenty on your shoulders.
Yeah.
And you don't need the doctor to add more by basically criticizing you for, instead, let's say something like, I'm glad to see you now. I'm glad you've come in to see me now. Let's get started.
That's so much better. If you just tuned in, I'm Jay Sokol. You're listening to Brazos Matters. My guest today is Dr. Leonard Berry, Distinguished Professor of Marketing at Mays Business School at Texas A&M. And we're talking about his new research on never words. Those are words and phrases that medical providers should avoid using with patients and their families. So your findings mention that more thoughtful, intentional communication from healthcare professionals, I think the phrase is redistributes power back to the patient. Explain why that matters.
Yes. Medical decision-making should be shared. The physician is an expert in the science of medicine, hopefully an expert in the science of medicine. The physician has had a lot of experience with other patients, and that's very valuable in diagnosis, and it's very valuable in treatment planning. But the physician is not the only expert in the room. The patient is an expert on herself.
Yeah.
And the patient is an expert on what he or she values the most. And so we have to think of medicine not only in the sense of what's the matter with the patient, we also have to think of medicine in terms of what matters to the patient. What matters to the patient, what the patient's values are, what the patient's priorities are, what the patient's fears are. And that's the kind of medicine that we need to practice.
Yeah. So here are some examples from my own journey with colon cancer, which was diagnosed in 2022. And I'd love to get your reactions to some of these examples. So I had barely awakened from my colonoscopy, and my GI doc told me he had found a tumor. And in the haze of all of that, I asked if it was malignant. And he replied, this is how he replied, "Oh yeah. Oh yeah." And that was like a dagger in my heart. And that was before my wife had even been brought back to join me. That was one example. And I don't think he meant harm, but that was the way that information was delivered. Guessing that could have gone better.
Yes, it could have gone better. It should have gone better. It was unintentionally, I don't know your physician,
Right.
but I presume unintentionally cruel.
Yeah. And he's an excellent physician. He is.
But excellent physicians, Jay, can only be excellent if they're excellent not only technically, but also excellent in their humanity, in their compassion, in their sensitivity to their patients. What was wrong in the story you've just told, the first time I've heard this story from you, my friend, number one, the timing. That conversation should not have occurred when you were just waking up, when you were still in a daze. And number two, the words themselves. That would have been a time for the doctor when you were fully alert, and for the doctor to be seated eye level with you, perhaps close enough to put his hand on your shoulder or your knee and say, Jay, yes, your tumor is malignant, and we can treat it, and we're going to work together, and we're going to do our very best.
So I've got a better example for you, though. Something that gives you a little more hope. So it was supposed to be a relatively simple laparoscopic surgery, and then I'd be back home in maybe a couple nights. But what they found was extremely complicated and messy. And according to my wife, my surgeon said, when we got in there, we found a couple surprises. And then he drew a picture so my wife could see what he had done, where he had done it, and she could understand. I thought both of those were pretty great. And then later, this surgeon told us, we'll call it a stage 4, but that sounds worse than it probably is. Which also I thought showed a little bit of grace and humanity. Because I was hospitalized for 12 days. My surgeon was always kind and honest and reassuring, but he never overpromised to us.
That is a much better example of the opportunity we have to put our best humanity forward in caring for our patients. A much better example, the second example, Jay, than the first.
And my oncologist, and I cannot imagine how difficult it is for the oncology profession to share all kinds of news with their patients and the patient families. But through my 6 months of chemotherapy, my oncologist's demeanor changed and evolved. Very serious, very straightforward, very honest, a little poker-faced, didn't show much beyond that. And as time went on, and as my numbers and labs continue to look good, and to now, it's been a little bit over 2 years, she engages with me in a very different way. And I think that's artful on her part. And I've never felt like she has said something wrong with us.
It is artful, and it illustrates that medicine, particularly serious illness medicine, is not only science, it's an art form. It's not only the technical diagnosis and the technical evidence-based treatment that you received, but it's also the kindness and caring and the relationship that you build and the trust between you two. So that you as a patient, as your relationship continues with your oncologist, you feel psychologically safe in expressing what's on your mind, in conveying your fears,
Yes.
in asking questions. And patients need to feel psychologically safe with their physicians, particularly when they're seriously ill. Because it's very easy for patients to put their physicians on such a high pedestal that they're reluctant to ask too many questions. They're reluctant to express a concern about a proposed treatment plan or proposed medication or proposed procedure. And we've actually, colleagues and I have written a paper on that issue where we referred to patients as hostages, because many patients actually act in the presence of their physicians like hostages do, where hostages are kidnapped or in a war situation, where they would act in deference to their captors for fear of offending their captors. In my research over the years, where I've observed hundreds and hundreds of doctor-patient interactions in the hospitals, in medical offices, I've seen that hostage behavior. And that's why the way your oncologist evolved in interacting with you is so important, because it gave you license. It invited you to be more comfortable in discussing whatever was on your mind and concerning you.
I have enjoyed this conversation so much. Dr. Leonard Berry, thank you so much for being with us today.
It's my pleasure. Thank you, Jay.
Brazos Matters is a production of Aggieland's Public Radio, 90.9 KAMU FM, a member of Texas A&M University's Division of Marketing and Communications. Our show is engineered and edited by Matt Dittman. All of our Brazos Matters episodes are available on YouTube and on podcast platforms like Spotify, Apple, iHeart, and Amazon. Also on the NPR app and the KAMU website. We would love for you to rate and review and subscribe so you never miss an episode, and maybe tell a friend or a family member about Brazos Matters. We would love for you to share that as well. If you have some story ideas, some topics, some guest suggestions, love to hear that too. Email me at jsokol@tamu.edu. Thank you so much for watching and listening. Hope you have a great day.